Our next presenter is Dr. Simon Lee. Dr. Lee is an assistant professor and pediatric cardiologist at Nationwide Children's Hospital. He also directs the Kawasaki disease program and the coronary anomaly program. He completed his fellowship at Mount Sinai Medical Center with an advanced fellowship in cardiac imaging, including echocardiography, cardiac MRI, and cardiac CT. And he will be presenting an interactive talk entitled One Picture Pediatric Diagnoses.
Hi, how's it going? Good afternoon. I'll try to keep everyone on their toes. I know it's right after the lunch hour, so, you know. My name is Simon Lee, as Dr. Hill mentioned, and I'm one of the cardiologists and imaging attendings at Nationwide Children's, and I'm going to be showing you guys one picture pediatric diagnoses, one picture in quotes because there's probably more than one picture, but let's see how we all do. I have no financial disclosures. The one disclosure I do have is that my day job is cardiac MRI and CT, as you all heard, and I know you guys have a debate coming up between what's better, echo or MRI, and so, you know, I'll try not to be too biased, but you guys can probably guess which way I would vote. But on to the next slide. So there's a couple of rules. First rule, there are no rules. No, I'm just kidding. There's going to be a couple of clips that I'll show, followed by a vote. Some of the cases will have multiple instances of voting. Obviously, you're allowed to change your vote, but just keep in mind why you voted one way or the other. Audience participation, of course, is a must. And then I'll try to point out certain things or make some interesting notes at the end of these cases. Next slide, please. So here's the first case. This is a parasternal long, sort of the reference view. All right, next slide, please. And here's a parasternal short axis view. And here with color. I might have made this one a little too easy. Next slide, please. So I believe you guys should be able to vote, actually. Yep, there we go. So just put your vote in. I will put mine in. Oh, actually, I am not allowed to vote, so I will let everyone else vote.
We have 39 votes. We still have quite a few people still holding out. There we go, a few more rolling in.
Don't worry, they're all anonymous. You'll only get some emails shaming you if it's wrong. No, I'm just kidding. All right, and then let's see, how do we see the results of the poll? Oh, there we go. All right, so majority chose VSD. To be fair, you know, I didn't show you enough. It could possibly be tetralogy of Fallot, although the aorta would be overriding the ventricular septum a little bit more in that parasternal long axis view. Next slide, please. So it was a VSD. So this is just a picture. There can be multiple locations for a VSD. I'm not going to get into the naming of it, you know, supracrystal, doubly committed, muscular, perimembranous, paramembranous. There are many names. We're still working all of that stuff out. But from a imaging standpoint, you just want to identify that there is a ventricular septal defect. Next slide, please. And that one was a membranous or perimembranous defect. So interrogation of the ventricular septum in multiple short axis and long axis views are important. Color mapping is pretty much obligatory and is specifically helpful for tiny defects that can be difficult to see by 2D. Sweeps from the base to the apex are important. There can be multiple defects. And then of course, spectral Doppler interrogation is important as well, just to evaluate for pressure restriction and directionality of shunt. Next slide, please. And then this is a left to right shunting lesion, typically results in left heart dilation after several weeks. And I mentioned that just because for those of you who scan in the newborn nursery, the left heart size can be normal in the newborn period. This is in contrast to an ASD, which would cause right-sided or right heart dilation. And on physical exam, or sort of the indication for the murmur for these, typically, or indication for the echo, typically is loud or harsh murmurs. Next slide, please. So here's the next case. This is really just one image. I will admit there could probably be a better image for this, but I'll let this play a little bit. This is in a suprasternal sagittal view. All right, next slide, please. I think we should be voting next. So A is coarctation, B is detransposition of the great arteries, C is total anomalous pulmonary venous return, and D is a right aortic arch.
So getting a few more votes, creeping towards 40%. For those voting in the Q&A, you can vote directly on the screen. You'll be counted in the poll answers.
All right, and that one was a tricky one. I will give you guys that one. It was the majority, 56% chose right aortic arch, and then the next highest answer was coarctation at 30%. Okay, next slide, please. So this one I think should have a couple of animations. So if you click one time, please. So it was a right aortic arch, and a couple of things to note. In the beginning of the sweep, you'll see the trachea. Now, typically you don't see that in adults and even older kids, but in infants and sometimes even in the newborns, you can actually see the trachea. And as the sweep goes, you can actually see the aortic arch going to the right of the trachea. And then on the right side of the clip, in the color box, you can see pointing out to the first head and neck vessel, and that's going towards the left, which would suggest a right aortic arch. And if you just click one more time. The other interesting thing here is that towards the end of the sweep, you can see an aberrant left subclavian artery. Right there, you just start to see some flashes of red. Next slide, please. So that would actually make this a vascular ring, or at least a substrate for a vascular ring. Here's just a diagram of what that would look like, and you can see the right aortic arch, and in the middle is the esophagus and the trachea, and then the first head and neck vessel, of course, is to the left, which is the left common carotid, and then you have the aberrant or retroesophageal left subclavian artery there, all the way at the top of the picture, and then that little sort of bulbous thing is the diverticulum of Commerell, and that would really be the way to tell if this were a vascular ring or not. And the ring is formed by the ligamentous adductus ligamentum, which is basically the remnant of the PDA. Next slide, please. So for vascular rings in general, suprasternal notch views in the short axis sweeps are important just to get a sense of the arch branching pattern. The first brachiocephalic vessel, of course, is leftward in this clip, and that's leftward and superior, and that's what confirmed that it was a right aortic arch. Trachea is occasionally seen, like I mentioned, but not always. And then the absence of proximal bifurcation is suggestive of the aberrant subclavian, which in this case we were able to see, but is not always the case. Next slide, please. And then right aortic arch with aberrant left, substrate for a ring, as we mentioned, and then the diverticulum is what lets you raises the suspicion for a vascular ring, and then the diverticulum can only really be seen with other cross-sectional imaging. Next slide, please. It should be the next case. All right, and these are actually 2 video. Yep. So I'll let this play a little bit. Oh, sorry. Actually, yeah, that bottom one is a still frame. Never mind, sorry. So here we are in the subcostal sagittal view, and I won't give away too much, but you can see at the bottom right, there's a pulse, a spectral Doppler pattern there. Okay, next slide. So now we can vote.
We got a few more participants this time. We're up to 43%, 44.
Don't be bashful, folks. Just bring it on in.
Keep the voting coming.
There's a prize at the end. No, there's not. I'm lying. The prize is the feeling of satisfaction that you had. All right. So yeah, we got a lot of folks who coarctation was 71%, transposition 4%, TAPVR 17%, severe AR 8%. In regards to the AR, I think with the this may be an adult versus peds thing, but typically the aortic spectral Doppler is up. And with severe AR, you'd expect sort of more of diastolic flow reversal. So there should be another spectral envelope on the opposite side of the baseline. Next slide, please. But I did throw that in there to fool some people, so I'm glad it worked. So here, this is suprasternal notch imaging again, not a happy camper, but now we're starting to see a little bit of what might be going on. It seems like the majority of voters were correct. You see this is the aortic arch, and then you see on the color Doppler, there's some aliasing at the distal arch. Next slide, please. And then when you Doppler that region, you will see this, and this is sort of that diastolic drag or continuous diastolic antegrade flow of that spectral Doppler, which, the next slide please, suggests coarctation. And actually, this is that patient's actual CT scan. The interesting thing with this person was, you can see they had actually a real ovine arch. All of the head and neck vessels were coming off one branch. All right, next slide, please. So coarctation was the answer. Best image from suprasternal notch view, or sometimes actually from high parasternal views, or sort of the strap muscle views. Imaging of the entire arch is important, not just the coarctation, just because transverse arch hypoplasia is actually probably the bigger differentiator in terms of surgical management and what the surgeon has to do or the approach that they take. Consideration for coarctation should be given whenever there's any other LV outflow tract obstructions, most commonly bicuspid aortic valve. If you see ventricular hypertrophy and or dysfunction without obvious etiology, coarctation, ruling out a coarctation is pretty obligatory. And I'm sure some of the other panelists have seen this more than I have, but certainly have seen a number of times the infant coming in with dilated cardiomyopathy and ends up that they have a critical coarctation. Dampened abdominal aortic pulsations with diastolic drag pattern, as we saw on that first slide, are some other clues to this as well. Next slide, please. So we're going to get a little more exotic now. Next slide. I should have put a picture of Tiger King there when I said we were going to get more exotic. So here's case 4. And I think this will be just one picture. So take it all in, guys and gals. Next slide. That's all you get. Vote. Let's vote on this one.
I think we probably reached the max voting, 46%.
Oh, very good. Okay. Well, obviously by my reaction, it's transposition of the great arteries. Next slide. And this, I think, has some animations. So if you could just click once, I think they should come up. Okay, so here you have, this is a parasternal short, and we have the great arteries in short axis view, and the arrow is pointing to the branch pulmonary artery there, and with two semilunar valves and a branch pulmonary artery coming off of that more posterior and leftward one, that suggests that, and if you click one more time, that is the MPA. And so we have the pulmonary artery, pulmonary valve, posterior and leftward, and then the aorta, anterior and rightward. Next slide, please. So, of course, suggesting transposition or some sort of malposition, meaning that the great arteries are not quite normally related. Here's another view. This is the parasternal long axis view, and you see sort of those parallel outflow tracts, parallel great arteries there. Next slide, please. And then anytime you have any funkiness of those great arteries, you just want to see what the rest of the heart looks like, just making sure that there's no double outlet or single ventricle flavor to it. And here I just put this up here just because you look at the forechamber and the ventricle on the left, you see smooth septal surface and not a lot of trabeculations. The ventricle on the right, you see a lot of trabeculations, particularly from the septum. And so this suggests to me that the atria and ventricles are normal. And so we likely have a detransposition here. Next slide. Oh, I guess we can skip this. Everyone got it. And so detransposition of great arteries, and this is an illustration. And actually, if there's a link at the bottom, or there's a web URL at the bottom. I just found this out while making this talk, but the CDC actually has these really nice images of all of these, or illustrations of a lot of the more common cyanotic congenital heart diseases. So just, I mean, I really like these. They look very nice. So just wanted to point that out. Next slide. So detransposition typically will have normal atrial and ventricular configuration. So right atrium to right ventricle, left atrium to left ventricle, right's on the right, left's on the left. The aorta most commonly arises from, or well, the aorta will arise from the RV and the MPA will arise from the LV, and that typically results in no crossing of the outflow tract, so you get that parallel orientation. And for those of you who do fetal, that's, or actually even part of the MFM and OB scans, there's supposed to be a sweep to look to see those outflow tracts crossing. And so with transposition, if they don't cross, then that's a hint or a suspicion that there may be transposition. Majority of these patients will have the aortic valve anterior and to the right of the pulmonary valve. And like I was alluding to earlier, when you have normally related or normal relation of the great arteries, you'll have the aorta, the posterior and rightward to the pulmonary artery. Next slide. Additional key features to image, and some of these are particularly important. Atrial communication, that tends to be one of the biggest questions when you have diagnosis of transposition. Restrictive communication can lead to inadequate mixing of blood, and that leads to cyanosis and need for urgent cath intervention. There are other levels of mixing, other sources of shunting like a VSD and a PDA, but the atrial communication tends to be one of the more critical features. Some of the other different flavors of transposition, you can certainly have unusual coronary artery patterns that can range from just a circumflex from the right all the way to a single coronary artery or intramural courses. Part of the coronary artery actually going into the wall of the aorta. Those can exist as well. The outflow tracts are important to evaluate, looking for obstruction, typically pulmonary stenosis. And then the semilunar valve anatomy is important to visualize. And the interesting thing, or the important thing to keep in mind here, is that almost all of these patients will get something called an arterial switch operation, where they literally just, take off the MPA, take off the ascending aorta, and just switch the valves. And so when you talk about semilunar valve anatomy, is it bicuspid or dysplastic, you really want to focus on the pulmonary valve pre-op, because that will become the neo-aortic valve after the switch. Next slide, please. So this actually is a subcostal sagittal view, sort of a bicaval view. And the thing I wanted to point out here is that sometimes these atrial communications can be very complicated. In this particular case, they had a foramen, so they had the PFO, but there were also two small fenestrations in the atrial septum. And so sometimes, depending on what the level of shunting is at the atrial septum, sometimes even though it's not large, it can be adequate for mixing. But in the cases that they're not, this actually may make doing a septostomy much more difficult. Next slide, please. And then just another interesting flavor to transposition, you can have something called juxtaposed atrial appendages. And if you look at the top of the image at that little cross-sectional picture, what this is both atrial appendages are actually on the same side of the heart. So the right atrial appendage in this case goes behind the pulmonary artery and is actually laying right next to the left atrial appendage. And it is interesting from an imaging standpoint, but from a clinical standpoint as well, this can actually, if you don't know, if your interventional cardiologist doesn't know about this and the patient needs a septostomy, they can, it can actually be very difficult in terms of the anatomy of the atrial septum for them to be able to do the septostomy. And then if the echo lab does not tell them, they'll be very mad. So that's probably the more important one. Next slide, please. So here's the next case. So this is a subcostal long axis view and sweeping sort of from the heart down. I wonder why. We don't usually go that direction. And next slide, please. And this is a subcostal sagittal view. Spending a lot of time on that area. Next slide. What could it be? Choice A is tricuspid atresia. Choice B is persistent pulmonary hypertension of the newborn. Choice C is total anomalous pulmonary venous return. And choice D is truncus arteriosus.
People are being a little bit more shy with this one.
It was a little tougher, I warned everybody. It's getting a little trickier.
Most of them are I think, on it. 2 more votes rolling in. There we go.
Oh, there you go. No need to be shy. Looks like the majority chose total anomalous pulmonary venous return. Okay, next slide. And then I think there's an animation for this one. If you could just click once for me, please. There we go. That's why we kept going in this view and sweeping downwards. Towards the end of that clip where the arrow is, you can see the vertical vein. And since we're in the subcostal view and the apex of the pizza pie or the pizza slice is at the bottom of the screen, the flow is red, so there's some blood flow going down below the diaphragm. One could even say infradiaphragm. Next slide, please. Oh, yep, there we go. And then this is a suprasternal short axis view. And what I am showing off here, since everyone pretty much had the answer, is we have this is almost like a, this is pretty much similar to the crab view. And then you see some pulmonary veins on the right side of the patient there in color. There's the blue flow, which is the right upper pulmonary vein. And you just see, instead of the right upper pulmonary vein flow going into the left atrium, it just continues to go away from the transducer there. And next slide. Oh, yep, there's the left atrium and then the confluence, yep. And then here's an apical four-chamber. And yeah, you can see that the right side of the heart just looks massive compared to the left side, and then the small left atrium. And then you see something else going on back there behind the left atrium, which is the confluence. Next slide. Yep, the confluence there. And then here's a parasternal short axis view. And I just wanted to show this just to demonstrate how a couple of things. One is that the RV is just huge here, much bigger than normal even for a newborn. And then you can see pretty significant septal flattening there, which is of course no bueno at any time. And so this, there's definitely evidence of pulmonary hypertension going on here. Next slide. So infracardiac or infradiaphragmatic TAPVR, totally anomalous pulmonary venous return. Some people like total anomalous pulmonary venous connection or drainage, whatever people prefer. But you can see there's several types of total anomalous pulmonary venous return. Next slide, please. You can have supracardiac, which drains to the innominate vein. You can have cardiac, which drains to the coronary sinus. And then you can have infracardiac or infradiaphragmatic, which drains below the diaphragm. Or you can have mixed, which you just have separate drainages of multiple veins, which tends to be the worst prognosis. The big thing with TAPVR is that the concern is for obstruction. And so it's important to look for evidence of pulmonary hypertension, which would suggest that there's some level of obstruction that's happening. And typically it happens mostly with infracardiac, although it can happen with supracardiac as well. Next slide. Normally there's two right and two left pulmonary veins to the left atrium, and then there's some really funny pictures of the crab view, which is from the suprasternal notch short axis, where they make it look like a crab or superimpose a picture of a crab. But that's typically the best view in smaller children, to see the two right and two left-sided veins coming to the left atrium. It's important to get clear 2D and color Doppler imaging from multiple views to demonstrate that the drainage or return is normal. The first clue can be from your apical four-chamber view. Typically, the right lower pulmonary vein is well visualized here. And in terms of just the regular imaging protocol, that tends to be part of the diastology, just getting a pulmonary vein Doppler. And so that can essentially rule out TAPVR if at least one vein is coming back to the left atrium there. And you should also consider it if the right ventricle is very big and the left atrium appears quite small. Next slide, please. All right, here's the next case.
Simon, there's been a request that we let that play a few times. I think it's a little slower at home.
Yeah, not a problem. People are still getting the right answer, though.
Yep, they're that good.
So this is and I'll also try to actually describe each view just so you're a little better oriented. This is a parasternal long axis view, and it's just the internet connection. They do not have SVT or something here. Okay, next. I think the poll is next, actually. That's all you get. Although this one might not be that fair. It probably isn't fair, actually.
Creeping up, a few more people still voting. Give me just a second more. Oh, we get a couple more votes. We hit 50%. All right, I think we're.
Okay. Ah, you all fell for my trap. Although this was not fair, I will admit. Next slide, please. The majority answer is tetralogy of Fallot. But I will show you some more pictures to make you wonder why, or wonder what else it could be. Is this one playing? So this is a high parasternal short axis. So you're above the level of the ventricles here, and you have a color compare. Yeah, so we'll let this play a little bit. Okay, next slide, please. And now this is an apical 4-chamber. It's a little off apex, and then we are sweeping from the feet towards the head and anteriorly. So basically from the IVC RA junction through the ventricular septum and into the LVOT and RVOT. Okay, next slide. I need that Toshiba regular speed and slow-mo side by side. This is a subcostal view, subcostal long axis or coronal, and here we're sweeping again from the feet towards the head and anteriorly. I'll let that play one more time. Okay, next slide. I think the next slide is a voting slide. Now it would have been even trickier of me to make that first comment at the poll, and then it actually turns out it is tetralogy of Fallot. Is that what I'm doing? I don't know.
Got a couple more trickling in. Get your votes in quick. All right, so I think we can close.
Ah, okay. Well, 8% of you are holding out for tetralogy of Fallot, huh? The majority of voters, 67%, chose truncus arteriosus, which is what it was. Next slide, please. So truncus arteriosus, specifically type 1, there are several types which I'll get into, but essentially the key features that I was showing in those clips is that there's only one semilunar valve, which is the truncal valve. There's a large VSD, an overriding of that truncal valve over the VSD. So from a parasternal long axis view, it can look very much like tetralogy of Fallot. But again, the key thing is that you only see one semilunar valve, and then you see the branch pulmonary arteries, whether they come from an MPA or separately, arising from the ascending aorta. Next slide, please. So yep, like I mentioned, outlet VSD, the single semilunar valve. It can be dysplastic and typically is multicuspid, the most common being tricuspid, but you can also get all kinds of variations, uni, bi, quadricuspid, and then the great artery overrides the septum. The four types in this particular patient that I got the clips from had type 1, which is that you have an actual MPA segment that bifurcates from the truncus, and that's where all of those subcostal and apical sweeps were showing. You see the semilunar valve and then the great artery, the MPA coming off of that bifurcating. Type 2 is where the branch PAs arise from separate posterior origins. They tend to be right next to each other. Type 3 is that they arise from separate lateral origins. And type 4 is actually probably just a tetralogy of Fallot pulmonary atresia variant. This is sort of the classic classification, and then there are some others. Von Prague has a different set of classification, but this tends to be the most common one that people talk about. Next slide, please. So associated lesions, this can also be found with coronary artery abnormalities. Right aortic arch actually tends to be a very common finding with truncus arteriosus. And then in that case, if you have a truncus arteriosus and a right aortic arch, tend to be a high proportion of genetic abnormalities. Atrial septal defect is a common one. Interrupted aortic arch, not so common, but typically can be seen with that. And then they often do not have a PDA unless there's an interrupted aortic arch. Next slide, please. Okay, here's the next one. This is a apical 4-chamber view. Okay, next slide, please. And then here again is an apical 4-chamber view. And this, I just kind of made a color compare here, but you can see the color box is over the right side of the heart. Okay, next slide, please. Should be the poll. So A is AV canal, B is tetralogy of Fallot, C is tricuspid atresia, and D is pulmonary atresia, intact ventricular septum.
All right, I think voting has slowed down.
76% of you said tricuspid atresia, which is correct. And that second clip I showed you guys where the color box is over the right side of the heart, you don't see any actual inflow into that right ventricle. Oh, what happened? Did we go to the... Oh, next slide, please. Yep, so this would be kind of similar to what you guys were seeing in that apical four-chamber view. There just is a plate-like atretic tricuspid valve there, so there's no communication from the right atrium into the right ventricle, and so it relies on obligate right-to-left flow across the atrial septum into the left atrium, left ventricle, and typically across the VSD. Next slide, please. So this is the third most common cyanotic congenital heart disease. And like I mentioned, there's absence of the right atrial, right ventricular communication. There's no inflow. There can be three types. There's normally related type. There's tricuspid atresia with DTGA, and then tricuspid atresia with LTGA. There's varying degrees of VSD size or pulmonary stenosis. And depending on what the great arterial relationship is, kind of determines whether it's categorized by VSD size or pulmonary stenosis. Next slide, please. Yes, so the things you want to evaluate are you want to evaluate the VSD size, whether there's any restriction across the VSD, if there's any degree of pulmonary stenosis or obstruction, and then in the case of transposed great arteries where the aorta is coming off of that right ventricle, depending on the VSD size and restriction, you can also have varying degrees of aortic arch obstruction. And so that's also important to look at. Next slide, please. Here's the next case. This is, again, an apical 4. And that atrial septum's doing something. It's dancing up there. Some of you may be thinking, this looks very similar to that last one. Is he just trying to fool us and showing us triatresia again? Next slide, please. And now here's a similar view. Again, with the color box over the right heart. Okay, next slide, please. This should be the vote. Oh, no. Let's play this one. So this is a parasternal short axis sweep, and the color box is over the right side of the heart. And the thing to note here is that you see some flashes of color within the right ventricle. I guess I'll leave it at that, not to give away too much of what I'm showing here. I'll let that play one more time. Okay, next slide, please. So A is anomalous coronary artery. B is tetralogy of Fallot. C is Epstein anomaly. And D is pulmonary atresia intact ventricular septum.
We've got a few more trickling in. And oh, there we go. All right.
All right, 61% of you chose pulmonary atresia, intact ventricular septum, and that is the correct answer. Next slide, please. So in this case, when you looked at the second set of images, you could see there was just a little bit of blood flow crossing a very hypoplastic tricuspid valve, which typically goes along with pulmonary atresia, intact septum. And in the triatresia case, you could see actually a VSD with flow going across. And this one, the septum was intact. And I was about to say that, but then I thought I would probably give it away if I actually said intact ventricular septum. But that third image was had to do with the presence of coronary sinusoids or fistulas, which I'll talk about in the next slide, please. So the pulmonary atresia, intact ventricular septum, or PAIVS as it's known, there's complete obstruction of the RV outflow and variable degrees of tricuspid valve and RV hypoplasia. And you can actually have an Epstein-like malformation with RV dilation, which is part of the reason why I put that Epstein in there to confound you all. But there is a significant association with coronary artery abnormalities, coronary cameral fistula or sinusoids. You can have coronary stenoses. You can actually have osteoatresia at the far end of the spectrum, and something known as RV-dependent coronary circulation. And the coronary abnormalities tend to have a very significant impact on what the management of these patients will be, with sort of the extreme case of if you have an RV-dependent coronary circulation and osteoatresia or significant coronary stenoses, or actually really more osteoatresia, you would think about primarily listing that patient for transplant versus actually trying any sort of single ventricle palliation. Next slide. I don't remember if I have I do have another case, but I don't remember if I have another. Oh yeah. So assessment of the tricuspid valve annulus is important for these patients. The only way to really tell if there are sinusoids or coronary cameral fistulae, and the only way to tell if there are RV-dependent coronaries is for the patient to get a diagnostic catheterization and angiography. But by echo, we can assist that by looking at the tricuspid valve annulus measurement and generating a Z-score for our interventional and surgical colleagues, just so that they have a better sense of what to expect. If you have a mildly or minimally hypoplastic tricuspid valve, then you're probably not going to have an RV-dependent coronary circulation, versus if you have a very severely hypoplastic tricuspid valve, then the suspicion is very high. It's also important to visualize the RV outflow tract, and what I mean by that is there actually an infundibulum that goes up to just a membranous atresia of the pulmonary valve, versus is there just so much, such a hypoplastic right ventricle that there's no infundibulum or severely hypoplastic infundibulum, where we would call that muscular atresia. And the importance of that, or both of these things really, is that you can potentially do or consider a biventricular repair or 1.5 ventricle repair with transcatheter valve perforation and balloon dilation. I think I have one more slide, Garrick, but I know it's 2:20, or I'm sorry, one more case. So I don't know if you think we should just try to get through that, or.
Yeah, I think we have time.
Okay. All right, let's play this one. Actually, probably two more, so maybe we'll just do this one. Okay, this is a parasternal short axis, and we're basically right at the aortic valve en face, or short axis. And I'll be honest, I don't remember what this one is, so I'm figuring this all out with all of you guys. Next slide, please. Oh, I'm sorry. This is still the same case. Here, I was just showing the pulmonary atresia here. So this was an example of a person who had actually muscular atresia. So they had very severe RV hypoplasia. And then what we see here is this is sort of the parasternal short axis trying to look at the RV outflow tract. And you can see that there's really nothing there. By the 2D image, you do see a little bit of a almost it looks like some sort of cavity. Maybe there's a vessel there, but that actually is the left atrial appendage. And when you look at the color Doppler, you'll see that when you look at that space and you're wondering, oh, is that an RV outflow tract? What is that? When you look at the color, you'll see to and fro flow. So you'll see flashes of blue and flashes of red in that chamber. And so that tells you that that's the left atrial appendage. And then you'll see further down at the sort of the southeast corner of that color box, that's the continuous ductal flow going into these pulmonary arteries and very diminutive MPA. And then you don't see any integrate flow there. Next slide, please. Okay, so this is a parasternal long axis view. This is the next case. And, you know, we're concentrating at the aortic root ascending aorta level. And here the sonographer is going from the reference view at the ascending aorta aortic root region and sweeping towards the left. And towards the end of the sweep, you see they're starting to fall into the pulmonary valve MPA region. I think that's as much as I can say without giving it away. But the hints, this is with just the 2D, this is a tougher one. The hint for this one would be look to see what is going on between the aorta and the MPA. And that might not be that helpful, but I think that's the best I can do. I'll let it play one more time. Okay, next slide. Okay, here's a parasternal short axis view. And the parasternal long axis view, we were looking to see what was going on between the aorta and the PA. So in the parasternal short axis view, I would do the same. And I'll let this play a couple more times. Okay, next slide, please. Okay, so this is the last case. Choice A is anomalous coronary artery. Choice B is tetralogy of Fallot. Choice C is Epstein anomaly. And choice D is bicuspid aortic valve.
I may have forgotten to mention early in the talk, if you don't vote for one of these, you don't get credit for attendance at the conference.
Uh-oh.
You don't qualify for the $50,000 prize either.
Yeah.
Provided by Cincinnati Children's, of course. Ah, there we go. 91% anomalous coronary artery. It's always this easy to diagnose anomalous coronary artery, right? Next slide, please. You are correct. All of you are correct. Well, 91% of you, I guess, technically. So yeah, here's the color compare. And certainly something suspicious going on. One might even say there's an interarterial something going on there. And when you look, you can see actually, and this one is, it's a little harder to see because of the clip, but and the 2D, you'll see that there is the commissure, so the intercoronary commissure is actually at about probably 2 o'clock, 2 to 3 o'clock there. And if you follow the color, you'll see that there is a left coronary artery coming from the right sinus of Valsalva or to the right of that intercoronary commissure. And then it's got the interarterial course there. And there's some actually aliasing of the color flow, which is concerning that there might be some sort of obstruction there. And just with that acute angulation, you think that there's probably an intramural course there. And this person actually presented with, I'm trying to remember if they definitely presented after an arrest, and I'm trying to remember if they needed ECMO or not. I think they just presented with a resuscitated sudden cardiac event. And this is actually, I will say, the third echo they got before we found this. And so I think anytime you have a sudden cardiac event, it's important not just to show the 2D of the color, but 2D of the coronary origins, but also to show color, and particularly to show color going from the aorta into the coronary artery, because parts of this clip you'll see you can actually catch the color flow going from the aortic root into that vessel. Next slide, please. Yep, and there's an interarterial course. So there are multiple flavors of this. This patient in particular had an anomalous left coronary origin with an intramural course, which is image D at the bottom right corner there. You can certainly also have anomalous right coronary artery. You can also have an anomalous left without an intramural course as well. Next slide. So anomalous origin of a coronary artery from the opposite sinus of Valsalva is associated with sudden cardiac death. And the congenital coronary artery anomalies are actually the second leading cause of sudden cardiac death in young athletes. The first, or number one leading cause being hypertrophic cardiomyopathy. There's many variations to the theme in terms of what course the coronary can take, what, you can have something, you can have a pre-pulmonic course, you can have a intraseptal or intramuscular or intraconal course. There's a lot of variations to the theme, and each of them are thought to have different relative risks of sudden cardiac death. But from a echocardiography standpoint, and this has been shown in multiple studies, echocardiography can definitely diagnose an anomalous coronary origin, but when you talk about the different variations in the intramurality, course, things like that, advanced or cardiac imaging is typically needed. Next slide. I think that might be the last one, actually. Oh, this is a screenshot from a recent, relatively recent, AATS expert consensus document talking about anomalous coronary arteries and making some recommendations in terms of imaging and management. But I put this up here just to see some of the different variations that they talk about. Left main coronary artery arising from the right sinus, either directly from the right coronary artery or as separate ostia. And you can have the coronary coursing anterior to the PA. You can have it posterior to the aorta. You can have through the intraventricular septum, or you can have interarterial between the aorta and the PA, which is what this patient had. Next slide. Oh, well, certainly some of the stuff that I already mentioned. Echo can reliably and accurately diagnose it, but it is technically challenging, can be difficult due to poor acoustic windows. 2D optimization of the imaging and high frame rate are a must. You have to demonstrate cine clips of 2D and the color flow, and you cannot rely on still frames, because I can find a still frame where it looks like there's color in the coronary and make it look convincing even though it's not. And additional identification of specific morphologic features cannot be reliably obtained by echo, but typically will need some additional cross-sectional imaging. Next slide. I think that was the last one. Yep. Look at that timing, 2:30.
That was perfect.
Thank you all very much. I hope that was enjoyable, and I hope you guys all learned something.
Really appreciate you giving us that talk. It was very fun and interactive. I hope the audience liked it as much as I did.